Okay, well, it's 12 o'clock now, so I'm going to get started. I'm going to say welcome again to everybody who is attending. Thank you for being here with the Leukemia and Lymphoma Society of Canada. We are proud to introduce today's presentation, non-Hodgkin's lymphoma, the progress in understanding and treatment. Today, we will have in our session Dr. Abi Vijenthira, who is a hematologist at Princess Margaret Cancer Centre in Toronto. She will provide an overview of the approach to non-Hodgkin's lymphoma and provide updates on recent developments in the management of these lymphomas. Before we begin, let me introduce myself. Again, I'm Leslie Ann Guiney, and I am the Community Services Lead for the Eastern Ontario region here at the Leukemia and Lymphoma Society of Canada. I'll be your moderator today for this online event. We do invite you to type your questions into the comments or the question and answer box of your Zoom webinar panel throughout this presentation. An LLSC member will monitor the questions, and I will read some of them aloud at the end of the presentation. Due to a large number of attendees and limited time, there may not be time to get to all of the answers to the questions asked, but please note that Dr. Vijenthira cannot answer specific questions about a person's health history or status. If we don't get to your question during the live presentation, a community services lead will contact you shortly. Today's presentation will be recorded so that you can watch it again on our website. Next slide, please. Are you looking for a spectrum of programs and resources, but you're not sure where to find them? We are here to help you, and we can help you you can connect with the community services lead in your area to receive personalized assistance and be connected with resources in your area. Reach out to us by calling us toll-free at 1-833-222-4884. Next slide, please. We invite you to visit our website, www.bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Next slide, please. On our website, you will find tailored information and resources, including those specific to non-Hodgkin lymphoma. This includes recorded webcasts, podcasts, fact sheets, animated videos, and much, much more. Next slide, please. Did you know that the LLSC has an application that you can use to track your symptoms and side effects, along with many other important items? You can download the free Health Manager app to help you better manage your blood cancer diagnosis. It includes medication reminders, meal planners, medication and side effects trackers, and it has the ability to be shared with your caregiver. This app is available for Apple and Android devices. Next slide, please. We also offer programs that can connect you with other members of the blood cancer community. We offer a peer support program where you can connect one-on-one with a peer volunteer. We also have virtual support groups to connect with the community services lead in your area to learn more. Next slide, please. It is now time to introduce today's speaker, Dr. Abi Vijenthira. Dr. Vijenthira is an associate professor of medicine at the University of Toronto and a staff hematologist in the Division of Medical Oncology and Hematology at the Princess Margaret Cancer Centre. She received her medical degree from the University of Ottawa and completed her internal medicine and hematology residencies at the University of Toronto. She completed fellowships in lymphoma at Princess Margaret and in CLL at Dana Farber Cancer Institute, and a Master's of Science in Clinical Epidemiology at Harvard University. Dr. Vijenthira's clinical practice involves the treatment of patients with lymphomas, and her research interests include population-based outcomes and health services research in patients with lymphoma. Thank you for being here with us today.
Thank you so much, Leslie Ann, and thank you so much for inviting me to you, Pascal, and the LLSC. I think it's really a huge honor, and I And I really appreciate all of the patients who've joined the talk today. I hope it provides some extra information and some kind of new areas that we've been delving into in the last few years in lymphoma. So I split my presentation today into 3 sections. So we'll start with sort of a general overview of non-Hodgkin lymphomas. And then because, of course, there's more than 50 different lymphomas, I thought that rather than us focusing maybe on the nitty-gritty of the treatment of each of them, I might share a few concepts in recent progress and understanding of these lymphomas. So we'll talk about the concept 1, which is sort of the heterogeneity of each disease and the diversity of each lymphoma. With one example. Then we'll talk about minimal residual disease or MRD testing. And then we'll talk about some immunotherapies that are being used now in some lymphomas. And then we'll provide a brief update on some COVID-19 information as well. And I definitely welcome you to submit your questions as we go along, and hopefully we can get to some of them at the end. So some of this might be very much a background, but I thought we could start just with sort of the very basics, talking about normal production of blood. So, as you probably know, in our bone marrow, which is in our pelvis, our long bones, our spine, kind of all over the body, different types of blood cells are produced by cells called stem cells that live forever in our body and produce these billions of these cells every day. So we have the red blood cells, several different types of white blood cells, and then the platelets that help to clot the blood. And so, when we think about bone marrow production, we can kind of directly outline these when we look at the complete blood count that we get when we test your blood when you come in for appointments. And of course, when we look at the white blood cell count, we can break it down into the different types of cells that are kind of listed here. And when we think about lymphoma, the cells really that originate lymphoma are these lymphocytes. Now, oftentimes we don't detect them in the blood that we're looking at, but the lymphocytes, which are comprised of these 3 different types of cells, live all over the body, so not just in the blood, but in our tissues. And one area they really like to kind of hang out, which I think of as a cafeteria for the body, is our lymph nodes. And as you can see on this diagram, there's lymph nodes kind of all over the body, including the ones that we can feel. So there's 3 types of lymphocytes, B cells, T cells, and NK cells. And when any of these cells go haywire, that's when we can unfortunately develop lymphoma. Now, lymphoma's name kind of originates from the fact that if we take a biopsy of a lymph node, that's what helps us to make the diagnosis of the lymphoma. So I've kind of illustrated a diagram of different lymphomas here showing how important the biopsy is to help establish what the diagnosis is. So on the top picture here, you can see a normal lymph node, and you can see these tiny little circles called follicles, which have a germinal center inside, and around the follicle is something called the mantle zone. And listed below that photo are some snapshots of different lymphomas, kind of showing you how different each one looks under the microscope. So the top one here is diffuse large B-cell lymphoma. We can see a diffuse infiltrate is what it's called, of these large cells. The second photo is follicular lymphoma. So these follicles that are normally in the lymph node kind of get expanded. The third photo is mantle cell lymphoma. So that's cells grow in kind of the mantle zone that's around each follicle. And then the last photo is CLL, or chronic lymphocytic leukemia. And you can see these kind of tiny cells through the lymph node. So when we think about lymphoma in Canada and look at the statistics overall, looking at the commonality of different types of cancer, non-Hodgkin lymphoma is overall the 6th most common cancer and is the most common of all the blood cancers. Hodgkin lymphoma, which is the other type of lymphoma, is very uncommon, but common in the younger patients, and we won't be discussing that today. So when we think about classifying lymphoma, we can usually broadly split lymphoma into non-Hodgkin's, which is 90% of lymphomas, and then Hodgkin's, which we won't talk about today. And then under the non-Hodgkin category, most lymphomas are the B-cell type, and then a small number are these T-cell or NK cell types. And each of these lymphoma subtypes can be further subdivided based on the behavior of the lymphoma. So a sort of classic aggressive lymphoma that we would think about would be diffuse large B-cell lymphoma. And sort of the classic indolent or slow-growing lymphoma would be follicular lymphoma. But if we look at the classification that we use for lymphoma, which comes from the World Health Organization, and we count them up, there's actually over 50 different types of lymphoma. So it's definitely hard to talk about each specifically, but I'll share kind of some broad thoughts on lymphomas. So, what are the common subtypes? So when we look at non-Hodgkin lymphomas, diffuse large B-cell lymphoma is the most common, followed by CLL, which is the second most common, which is slow-growing lymphoma, and then follicular lymphoma, and then we see some other ones in there, marginal zone, mantle cell lymphoma, and then peripheral T-cell lymphoma would be the one of the more common T-cell lymphomas. And a message I like to think about or share in terms of lymphoma is this sort of spectrum of behavior. So on the one end, we have the more aggressive lymphomas, such as diffuse large B-cell lymphoma, or among the T-cell types, peripheral T-cell lymphoma. And over on the other side of the spectrum are the slow-growing lymphomas. So some examples would be follicular lymphoma, CLL or chronic lymphocytic lymphoma, leukemia, marginal zone lymphoma, Waldenstrom's, and lots of other different subtypes. And a common slow-growing T-cell lymphoma would be mycosis fungoides as an example. And then mantle cell lymphoma falls somewhere in the middle, so not quite aggressive, not quite super slow-growing. And kind of thinking about their behavior also helps us kind of think about how to treat and how we think about the growth of these lymphomas. So the aggressive lymphomas, as the name would imply, tend to grow quickly over a period of weeks or months. But because chemo or sort of the traditional treatments do work very well on fast-growing cells, all of these lymphomas are generally considered curable. So normally, as soon as we find that, we would want to think about treating it regardless of whether someone's having symptoms or not. And on the other end of the spectrum is these slow-growing lymphomas. So oftentimes these are found because, your family doctor did a blood test or you had a scan for a different reason. And so often they've been there for maybe some years even before we find them. And typically, with some rare exceptions, these are not curable lymphomas, but they're very, very treatable. So people have done studies over the years trying to see, if we treat the lymphoma sooner, can we make people live longer? And we've never really been able to show that we're making people live longer by treating these slow-growing lymphomas sooner or as soon as we find them. So really our aim of treatment is to control the disease if it's causing problems or symptoms. And there's different criteria that people use, but I find they're very intuitive in terms of the symptoms that the lymphoma causes or the blood count problems that it can cause. And this term that you may hear is this sort of risk of what we call transformation. So there's a 1 to 3% risk per year, depending on the different types of lymphomas, of the lymphoma changing and potentially becoming something more aggressive. And it's just important to know because if you know your body, if something's not quite right, if your symptoms are changing quickly or your lymph nodes are growing quickly, especially in one spot, of course, that would be a reason to touch base with your oncologist. So what are the symptoms of lymphoma? So these sort of vary from person to person and lymphoma to lymphoma, and it's definitely possible to live with no symptoms from your lymphoma. But some of the classic ones that we think about would be enlarging lymph nodes, unexpected weight loss, drenching sweats, or you might have to change your clothes, unexplained fevers without infections, tiredness affecting function. And lymphomas kind of come from the blood, and the blood goes all over the body. So really lymphomas can affect any organ. So, some ones that we might think about would be the brain or the skin. But really, because lymphoma can cause different symptoms that don't necessarily match this list, usually I might think that if any symptom is sort of persistent and progressive over 1 or 2 weeks, could be something to bring up with your oncologist. So how do we diagnose lymphoma? So a core biopsy is usually done, which is where a piece of a tissue, typically a lymph node or something else, might be taken out, or an excisional biopsy, which is where the whole thing is cut out, for example, a lymph node. And we'll come back to these 4 categories later, but we would send the pathology to the lab, and our pathology colleagues would do a few different things, like 4 different categories of things that they do. So first they look under the microscope, and that might help give a clue as to what lymphoma they're dealing with. then they would add some stains where they try to look for different markers on the cells, and we'll talk about this more in a later slide, and try to look for a pattern of these different markers. And then if they think it's necessary, they can send off chromosome testing of the genetics of the lymphoma or molecular testing for the genes or proteins that the lymphoma is producing. And then in terms of staging of lymphoma, you may need a CT and or a PET scan depending on the lymphoma type, and you may or may not need a bone marrow or other tests like a spinal tap, and that kind of comes down to the type of lymphoma you have and what your oncologist recommends. But typically, most lymphomas are staged in the same way. So when we think about staging, stage 1 would be kind of one spot or one lymph node area of the lymphoma. Stage 2 would be 2 different lymph node areas. Stage 3 would be using the diaphragm and saying if there's lymphoma above and below the diaphragm, we would call that stage 3. And stage 4 would be if the lymphoma involves the blood or the bone marrow, the liver, the brain. There's certain spots where we would call it stage 4. And the stage I usually would say is very different than people use in solid cancers like breast cancer, pancreatic cancer, where I usually would tell patients that the stage more tells us where it is and how to treat. But even stage 4 lymphoma can definitely be very, very treatable. So how do we treat it? And it's very hard to go through a lot of specifics, but the treatment depends on the type, the stage, how much there is it bulky or big? And then of course, personalizing the treatment to you. So your age, your health, what other medical problems you might have. And oftentimes there are really good guidelines, international guidelines, national or provincial guidelines, or even hospital guidelines of what oncologists would do for treating lymphoma. But at the end of the day, we always want to personalize the treatment to the person, especially in lymphomas where we have different options available. And sometimes there are trials available. So if you're interested in that, you can always talk to your oncologist and see if that might be available for your situation. So I think in general, I wanted to chat about sort of the goals of treatment, thinking about aggressive and slow-growing lymphomas. So with all lymphomas, of course, we definitely want to prioritize quality of life. And with aggressive lymphomas, we also want to think about a long-term remission and potentially a cure. So I mentioned that with aggressive lymphoma, right away, as soon as it's diagnosed, if someone is thought to be, fit for treatment, we would want to treat it. And really our first goal is to get the lymphoma into a remission. And so usually that's done at the end of treatment with scans or other tests to kind of prove to ourselves that the lymphoma's gone away, ideally gone away completely. And then of course, goal 2 is that time passes and we can say, okay, we've cured the lymphoma. And for most lymphomas, we would wait about 5 years and then say that the lymphoma is probably cured. And during that time, unfortunately, there can be a risk of relapse or what we call refractory disease. And in that situation, oftentimes we would think, is there another treatment available and can we try to get into remission again? And sometimes that can happen more than once. And I think at the end of the day, despite all of the various treatments that we're doing, we always want to think about the person and the quality of life that they're having and not let the treatments interfere with quality of life. And what about indolent lymphomas? So in most cases, we would do this. There's sort of rare exceptions of where we might treat right away. But typically, we would want to treat when the lymphoma is causing some problem. And again, think about quality of life. So usually with an indolent lymphoma, it would be diagnosed. And oftentimes some years might pass before it gets to a point where we say, okay, it's causing some problem or it's grown to a point where we should treat it. And then ideally, we give a treatment that leads to a remission, not a cure, but a remission. And we want that to last as long as possible. So time passes and, at some point, these lymphomas do tend to grow back. And just because it grows back, we don't have to treat it. We can kind of monitor it again until it causes a problem or we think it's important to treat. And then we would think about treating again. And usually as we do more and more treatments, the length of the remission might decrease, but oftentimes there are good treatments for when the lymphoma comes back. So what are the treatments used in lymphoma? So there's 8 categories I wanted to share with you. So I'll start the first 4. So chemotherapy is sort of the classically known one, and usually that's intravenous chemotherapy that gets given through an IV, but it can also be oral. I've listed a few drugs that you might have seen or received in the past, but there's lots of different chemotherapy drugs, and they all work in different ways. But the principle of all chemo is really that chemo is very good at killing cells that are growing. So it's very good at killing lymphoma cells if they're growing, but unfortunately the side effects of chemo are that it also kills other good cells that are growing, like often our hair cells, our mouth cells that might cause mouth sores, or our blood cells, and that's why our blood counts can go down on chemo. The next category, which is sometimes or often added to chemotherapy, is monoclonal antibodies. So these are antibodies that are directed against a target on the lymphoma cell. So a couple of classic examples are rituximab and obinutuzumab. And with any of these antibody type treatments, you'll recognize them by seeing the mab at the end, which is the end of all of the antibody treatments names. The next category is antibody drug conjugates, or ADCs. And it's really the same idea as an antibody, but whereas an antibody alone would help the body identify the cancer cell as something to kill, the antibody drug conjugates not only do that, but they're attached to some chemo that they try to inject directly into the cell rather than the chemo going all over the body. So it's thought of as a more directed type of treatment. And a couple of examples would be drugs like polatuzumab or brentuximab. And then a whole other category would be what we call targeted treatments. So these are often pills, but sometimes in some circumstances could be IV. And these are treatments that are very, very tiny molecules. They go right into the cell and targeting the lymphoma cell, trying to shut down a way in which the cell is trying to grow. So usually targeting some kind of enzyme or protein inside the cell. So a few examples of that would be ibrutinib, acalabrutinib, zanubrutinib, or venetoclax. And then this slide is showing the immune type of therapies. One example would be stem cell transplants. So we have 2 types of stem cell transplants. Autologous transplant is basically where we would take those baby cells that grow the blood in everyone and live in all of us forever, save them in the freezer, give someone chemo that is hopefully going to kill off all the remaining lymphoma cells, and then give back the stem cells or the baby cells to try to grow all the normal blood again. And an allogenic stem cell transplant is a different concept where we would we're not relying on the chemo to kill the lymphoma, but we're trying to use someone else's immune system to kill the lymphoma. So this is where it's kind of more rarely used in lymphoma now, but if we do use it, it's where we would take the immune system of someone else, maybe a sister, a child, or a sibling, or even someone unrelated, take their stem cells and their immune cells and give them to the person and hope that their immune system will see the lymphoma, think it's something bad, and kill it off. Other categories, so immunomodulators. So lenalidomide is a drug that has been used in lymphoma, kind of trying to activate the immune system against the lymphoma while also trying to kill off the lymphoma cells. And then we'll talk more later on about CAR T therapy and BiTE therapy. So CAR T is, we'll cover it in more detail later, so I won't go through it now, but there's a few different examples that are listed here. And BiTE therapies we'll also talk in more detail about, but these kind of have the MABs at the end because they do kind of use a linker to engage the immune system. Okay, so another question, kind of just being in Canada and in our public healthcare system, is, how do we access treatment? Do we have the latest treatments in Canada? And I would say that for the most part, we definitely do keep up very well with other, international bodies like the US, Europe, But of course, every country has its own really strict criteria for how it assesses whether drugs are safe and whether they're effective. And so our process is kind of listed here. And of course, it starts with a study being done that shows that a drug works, and ideally it's a very high quality study that is published. And by high quality, I mean the best type of study is what we call a randomized study, where people compare one treatment against the other. And usually we would want to compare a new treatment against what we've already been doing and prove that the new treatment is actually really better when directly compared against what we've already been doing. And then Health Canada would review all of that data and approve the treatment. And the next step is there's a nonprofit body that really is looking at the treatment, trying to understand, is it effective? Is it cost effective, and should it be funded? And they often seek, or they always seek, patient input and physician input into their decision making. And the next step, if they agree that this is a good therapy that should go forward, each province does its own work to decide about funding it and kind of negotiating the price with the drug company. So this process can often take years, but I think the goal is always to move things along as quickly as possible. And sometimes treatments may be available before this whole process is finished through other means, such as private insurance, compassionate programs, or even through participating in studies. Okay, so that concludes that sort of broad overview of lymphoma. And next I'll move into these sort of general concepts of lymphoma. And I'll start with the first one, which is sort of the diversity or the heterogeneity within each lymphoma. And to do that, I wanted to share one example of diffuse large B-cell lymphoma. So to talk about diversity of lymphoma, we have to go back to that pathology that we were talking about earlier, where I mentioned that the pathologist does these 4 things. And the first one with the markers on the cells is really looking at the cancer cell and what is on its surface. What can we use to stain and identify that, yes, this cancer cell is showing this thing on its surface, and that pattern can help us differentiate different lymphomas and also subclassify different lymphomas. We'll talk about that in a second. The chromosome testing is going inside the cell, looking at the genetics of the DNA within the lymphoma cell. And the molecular testing is looking at, what proteins are these genetics making, and what is the cell really doing? And putting those 3 things together can help with classifying lymphomas. So one example that I think we've learned more about in the last couple of years has been the most common aggressive lymphoma, called diffuse large B-cell lymphoma, or DLBCL. So if we take that very simple thing of adding some stains to the cells and looking at the markers that are on them, we can actually differentiate or subclassify the diffuse large B-cell lymphoma into 2 different types, non-GCB and GCB. And then we can actually go one step further. So in research studies, unfortunately not available as standard practice right now in Canada, would be something called molecular testing, where can further look at what genes is the lymphoma making, and further understand that some lymphomas are GCB, some are ABC, some are unclassified. And then further work that was done in the last couple of years found that actually this lymphoma can be further divided into 7 different subtypes. And why does that matter? I think it matters because of, of course, treatment. Maybe under the microscope they look the same, but if these are actually different subtypes, maybe it makes sense to target different drugs at these different subtypes, and people have identified different drugs that might work better on certain subtypes. And why does this matter right now? Well, even using the very simplest thing that I mentioned at the beginning, people did a study where they kind of looked at people who had diffuse large B-cell lymphoma and found that, hey, people who have non-GCB actually tend to live less long when they get the same treatment. So knowing that helped us understand that, okay, maybe we should target specific drugs that might work better on this subtype. And there's studies ongoing right now to look at that, and hopefully we'll get the results of one very exciting one in the next couple of years. We've also found that certain drugs may work better for patients with this particular subtype. So I think further subclassifying lymphoma hopefully will help us design studies that may identify better treatments for different subtypes. And that's just one example. This is true really across the board. So treatment decisions for many lymphomas, including but not limited to follicular, CLL, mantle cell Waldenström's, peripheral T-cell lymphoma, are based on putting together this whole diversity in how they look, what the markers are, what the genetics are, and what the molecular findings are to help personalize treatment to the person. Okay, so we'll move on next to concept number 2, which is this term that you may have heard about called minimal residual disease, or MRD testing. And this is some progress that's been made in the last couple of years in predicting how long remissions will last. And there are some drawbacks to MRD that I'll also kind of chat about a little bit. But first, what is MRD? So I think of it as an iceberg. So the lymphoma we see or feel with our own hands is the top of the iceberg that we can easily identify. And then right at the surface of the water is, let's say we finish treatment, we look at the blood tests, we look at the scans, we don't see any more lymphoma, we're in a complete remission. That would be kind of the limit of what scans or blood tests can do. And then MRD is trying to use more fancy tests to go below the surface. Are there teeny tiny cells there that we can't identify on normal blood tests or on scans? And I think people think that if we go deep enough, somewhere the iceberg will end, and that's where we probably have cured it at the outset. But MRD really is not everything, and people have done good work really showing that MRD really doesn't fully explain why people relapse. So some people can have MRD be positive, but still not relapse for a very, very long time. And it's probably because there's other aspects of the lymphoma that matter as well, like those things that we talked about on the previous slide of the molecular, the genetic features of the lymphoma. So what really is MRD testing? So if we think about a tumor and all the cells and all the DNA inside the cells, and our veins that are kind of going and touching the lymphoma cells, when these cells die, they release stuff into our blood. And, even when they're alive, they release the stuff into our blood. So there's different types of MRD testing. So a couple of examples would be cell-free DNA or circulating tumor DNA, where we can try to find these little pieces of DNA using a blood test. And then flow cytometry is another type of MRD test where we can look for these teeny cells that might be floating around in the blood that we can't see with other tests. So one example of where MRD has been more established for a longer time is chronic lymphocytic leukemia, which is a slow-growing lymphoma. And an example was this study where they took people who had a good type of CLL, but really the good type is the one I want to talk about or focus on. So really good risk. They gave them 6 months of treatment. After the 6 months, they did an MRD test, and then they followed these people for 20 years and just reported their results last year. And in people whose test was negative at the end of treatment, after 20 years, 80% still had not had the CLL come back. So it was amazing to know that you could predict that way, way long ago, 20 years ago. But this is a drawback of MRD because, if the MRD test was positive, I probably would have felt pretty worried about that and worried about maybe when the CLL might come back. But, 20 years later, 30% of people were still in remission. So I think this really nicely shows that MRD is really not everything and sometimes can cause worry if it's positive. So these are some of the limits. So these are kind of all of the limits I can think of right now with MRD testing. So right now it's being studied in different types of lymphoma, but really it's not available for, sending a test for your lymphoma right now for all types of lymphoma outside of research studies. And really right now, what we can do with MRD is really just predict how long the remission will last, but it's not 100% accurate. And it really doesn't impact treatment. So even if it's positive at the end of treatment, we really wouldn't know what to do with that. So really, it may not be that useful to send a test and have it come back positive if we don't know what to do. But I think what this shows us is we definitely need new studies to tell us, if the MRD test is positive, what should we do next? And will it make a difference? And if the MRD test is negative, can we stop treatment early, and other types of questions? So it's kind of an area of study, but I would say not quite ready for prime time. And then finally, we'll talk about immunotherapies in lymphoma. So the concept with immunotherapy, as we saw on one of the previous slides, is really harnessing the immune system to fight the lymphoma, rather than using drugs to fight the lymphoma. So the most classic, I think, well-publicized example would be CAR T therapy. So this is a busy diagram, but I'll kind of walk you through the steps. So CAR T is trying to use our own T cells, or immune cells, to fight the lymphoma. So we would remove the T cells from the body through an IV, send them off to a lab, and basically train the cells to find lymphoma cells instead of to find, bacteria or viruses or other things. So they train the cells, they grow them, they grow, on average around 200 million cells. And then we give those cells back to the person, and now these cells can rev up, can multiply and divide and do things that an immune system would normally do to fight an infection, but instead be trying to fight off the lymphoma. So it's a very exciting concept. And right now, CAR T is approved for 3 main lymphomas in Canada, but in the future, this may change. We may see it used in different types of lymphoma beyond these 3, and we may see it being used earlier on in treatment, and those studies are ongoing. So right now it's approved by Health Canada for 2nd and 3rd line treatment of aggressive B-cell lymphomas. We're still waiting for funding for the 2nd line. It's approved for 3rd line treatment of follicular lymphoma, though we are waiting for funding. And it's approved for relapsed mantle cell lymphoma after using a type of drug called a BTK inhibitor. So what are the upsides? So it does have this potential for cure in aggressive lymphoma. So in long-term studies, when used in the 3rd type of treatment, it seems to cure around 30% of people. And maybe would cure more if we used it earlier on in treatment, and that's why people are studying it in earlier treatments. And we think it can cause a long remission in other lymphomas too. It's just that those studies are kind of newer, so we don't have those many years of follow-up to see, how many people did it work for a long time. So we're not sure yet if it can cure other types of lymphomas. What are the downsides? So CAR T can only be delivered at certain hospitals. It's only available in 3 provinces right now. And so it can be difficult to access, long drives, plane rides, etc. The waiting time, we have to wait around 3-4 weeks, sometimes longer, for the T cells to grow. And that might be a long time to wait if you have an active lymphoma. And CAR T can cause short-term side effects, a lot of inflammation in the body. Sometimes the inflammation affects the body, sometimes it affects the brain. And then long-term side effects of causing low immunity, low blood counts. And so I think it's very exciting, and hopefully in the future, we'll figure out how to optimize some of these side effects and optimize how well CAR T works. And the other kind of exciting immune therapy where different drugs have become approved in the last really 1 year is bispecific T-cell engager, or BiTE therapies. So this is another immunotherapy, and instead of having to grow the cells in the lab and wait for that and then give those cells back to the person, it's something that's called an off-the-shelf therapy, which means that you can just grab the bottle and give it to the person right away. And that's because BiTE therapy is just a molecule, and it's a molecule that tries to connect your immune system, sorry, the light in my office, connect your immune system to the cancer cell and basically link them together to encourage your immune system to kill off the lymphoma by itself. So currently it is approved for the 3rd line treatment of aggressive B-cell lymphomas in certain situations. But it's definitely been studied in numerous other lymphomas, and hopefully in the coming years we'll see BiTE therapies being available for other reasons as well. And it has similar upsides to CAR T. So hopefully it can cause long remissions in many people, although we need more years of follow-up because these are newer treatments to understand how long the remission will last. And the other upside is it can maybe potentially be delivered at local hospitals rather than people having to come to certain centers to give these treatments. Downsides, we're still waiting for funding, and it has very similar side effects to CAR T in terms of acute side effects or long-term side effects. So those are sort of the three concepts I wanted to talk about in terms of our progress in understanding and treating lymphoma. And I thought I would close with just a couple of brief comments on COVID-19. So really just four things I wanted to share. So, I think even now, let's say you haven't done your vaccines yet, we would still recommend those 3 minimum doses for people with blood cancers as what's called a primary series or the non-booster series. And a study that was done in Ontario actually showed that getting 3 doses compared to 2 improved how long people with blood cancers lived. So very important to get 3 doses. I would say also important to stay up to date with boosters because, as you know, COVID is always changing and the variants that are out now don't really look like the variants we had originally. And so we want your immune system to be equipped with the knowledge of how to fight off the most recent variants. Another study done across Canada, which is still in progress in terms of the analysis, showed that as time passed through the pandemic, all the way up to more recently in the last months, more and more people have developed anti-COVID antibodies with time, approaching more than 80-90% in different groups of patients. And this is probably showing the effect of people getting their booster doses and, getting COVID and your body developing antibodies from having had COVID, what we call natural infection. So, at the beginning of the pandemic, the chance of dying if you had a blood cancer and you had COVID before we had vaccines was very high, and it was very scary. And it still is really scary to know that COVID is still going around. But I think something that's very optimistic is back to that study that was done in Ontario that showed that in people who'd gotten at least 2 doses of COVID vaccine, they still had more chance of, going to the emerge or going to the hospital, or, even dying from complications of COVID. But, and it was still higher than people who had no cancer. But it was less than 5% now over a 1-year period, which has decreased dramatically compared to when COVID first came out. So we've definitely made progress, and it really illustrates how important vaccines are. And finally, what's changed in the last, 1.5, 2 years is that now we have treatments for COVID. So it's really important to keep those rapid tests at home, get them for free from your pharmacy. If you're feeling a cold, do the test, and you can inform your healthcare team, even your pharmacist. If your healthcare team is not accessible, your pharmacist can prescribe this on their own without a doctor, to let them know if you have COVID and see if you're a candidate to get treatments for COVID. And there's a couple of different treatments that are available. So that takes us to the end of these 3 concepts. I hope that was helpful, and I'm very happy to take questions now. Thank you so much.
So thank you for being with us today. That was a wonderful presentation. And it is now time for question and answer. So if you have not done so already, please be sure to use the Q&A box in your Zoom webinar panel to type your questions. As we mentioned earlier, there is a lot of questions because there's a lot of you here today. And we might not get to all of the questions. So if we don't despair. A community services lead will get back in contact with you very soon to try and help answer your questions. So here are a few of the questions that were asked. Let me just reopen up that box and I will read some of them. So first of all, Dr. Abi, there's a little bit of a compliment for you here. It says, Dr. Abi, it's a treat to see and hear you here today. I am always so very happy when I get to see you when you're in clinic. So just let you know they love you, and we'll start with the first question here. Is there a genetic component to follicular lymphoma?
Yeah, it's a good question. With all of the non-Hodgkin lymphomas, there is some sort of genetic component we know, and that's because when we do studies on families, we can see that first-degree relatives have a 2 times increased chance of lymphoma compared to what would be expected. Now, the trouble is that unlike certain breast cancers where you can find the BRCA mutation or something like that, there's no clear genetic test that we can do that would tell someone that they're at an increased risk for lymphoma. And lymphoma doesn't have really any early screening or prevention programs. So usually what I would say is to let your family members, if you're comfortable, of course, to share that you have lymphoma and that, it's just important for them to have a family doctor, someone they can go to with concerns. And 2 times sounds quite high, but if we think about the lifetime incidence of lymphoma, meaning the chance you'll get it in a lifetime, it's about 2 or 3%. So if we multiply that by 2, then a first-degree relative would have a 4 to 6% chance of lymphoma. So odds are they won't get lymphoma, but also good for them to be connected with a doctor if they develop any symptoms.
Perfect. Thank you for that answer. The next question is, does the risk of transformation reduce the longer you are in remission?
That's a good question. I think that it may depend on the situation, but I will say that some studies that may point less towards that is those early treatment studies where if we treat lymphoma early and people are in remission for longer, do they have a less chance of transformation? It didn't seem to be the case in one subtype of lymphoma. But it's hard to answer that for sure. If the lymphoma has been gone for 10 years, is it gone forever? And we still don't really know the answer to even that question. So I would say a tough one to answer.
Okay, well, thank you for trying. Next question is, why is slow-growing lymphoma, like marginal zone type, not considered curable?
Yeah, that's a good question. I think it's because, well, traditionally when we think about treating cancers, back when we used mainly chemotherapy, we would think that chemo works on rapidly dividing cells. So if the cell is not rapidly dividing, maybe it's, some of the cells are asleep and maybe they don't get exposed to the treatment. And I think that's kind of where probably the concept originated. But I think really in studies that have been done, there is, unlike aggressive lymphomas, where we see that after a period of time, it's very rare to have it relapse. We see that in these slow-growing lymphomas, even many years later, 10, 15 years later, the lymphoma may still have a chance to come back. And so it's based on that concept that we do need to keep following people because of that small chance that it could come back, even if it's in remission for a long time.
Oh, that's very interesting. If lymphoma transforms from indolent to aggressive, does that mean it could potentially become curable?
Yes, the goal at that point would be to cure or get rid of the aggressive component. Although we know we wouldn't cure the slow-growing component, so that one would still need to be monitored.
Okay. Is it possible to have two types of lymphoma, such as marginal zone and another aggressive type? And does that decrease longevity?
Yes, so it's possible to have 2 separate processes where it's thought that the aggressive lymphoma is not related to the slow-growing lymphoma, and your oncologist would have to kind of weigh in on that situation. But oftentimes, if we saw the aggressive lymphoma develop after the slow-growing one, we would think of it as a transformed component. Does it affect longevity? Every lymphoma has its own survival information based on, your stage, your age, and other risk factors. And so all of that would have to be combined in that particular circumstance.
Okay. The next question is a little bit different. Can someone go to a different province to get treatment if treatments are varying from province to province?
Yeah, that's a very good question. And I guess this gets into how healthcare funding works, I guess, across Canada. And it's a bit of a complicated answer because generally, in terms of your health card, like let's say you live in Alberta and you have an Alberta health card, that will cover you for emergency treatments anywhere in Canada. So if you're traveling and you get sick and you have to go into the emerge, like you will not have to pay, of course, for your healthcare. But there's usually some sort of time limit on it that may be imposed by the province. So if one were to move for treatment, one would really usually have to move and, you know, get a different address and all of that. But, you know, it's really hard to, I guess, speak broadly about it. And I think that in general, provinces are very, very similar in terms of approval of drugs and funding of drugs and access to drugs through compassionate or free programs. And I would really hope that you could try and access really good care where you lived. And even if it didn't look exactly the same, like maybe it's something that could be still tailored to you. Because I think thinking of uprooting one's life to access a specific treatment may not always make sense.
Okay, I think we've got time for a couple more questions. I'm going to ask questions till about 12:55, and then we're going to close up. But how long has immunotherapy been used, and what research is actually done to show its effectiveness?
Yeah, that's a good question. I think if we define immunotherapy as including drugs like rituximab, which is the antibody treatment, that's been around since the early 2000s. So more than 20 years of basically trying these targeted therapies against lymphoma. In terms of some of the more recent immunotherapies like CAR T therapy, they've been around for several years now. And each of these drugs or treatments that is approved is only approved because a good study was done with patients that, you know, Health Canada and each provincial body that was looking at the study thought, yes, the study was well done. It represents people properly that have this lymphoma. It's effective, and most importantly, that it's safe.
Okay, is there a formal method of sharing non-Hodgkin lymphoma learnings across various hospitals, labs, and universities in Canada?
Yeah, that's a good question too. So I guess there's different ways in which learning is shared. So within each province, as well as across Canada, there are guideline committees that are put together, as well as different oncologists that get together to talk about the different drugs that are upcoming and funding for them. And really with the guideline committees, this is where knowledge is really shared, and we make sure that people across, you know, different regions would agree that, yes, this is what we should be doing. So that's kind of one formal aspect. And the other one is rounds. So there's often rounds where oncologists across different regions will get together and hear a talk and share cases and ask questions. So I think there's definitely lots of different ways that people try to share knowledge and learnings, especially with some of these new therapies where, you know, maybe one hospital starts using it sooner, and it's good to kind of share how it works in the Canadian system.
Okay, and for something like follicular lymphoma, is there a general idea of how many times it can be treated before it's no longer treatable?
Um, I wouldn't really put a number on it. I think decisions about treatment always come down to function and how well someone's feeling. So if you know you're living a normal life, taking care of yourself, up and about, then that's really what dictates whether another treatment can be tried or another clinical trial could be tried. So there's no specific number I would put.
Okay, well, I'm going to end the questions there because there are many of them, and I know we're not going to get to them all. But if we could go to the next slide, um, I will continue the presentation and just invite you to the second webcast that's being presented on lymphoma during lymphoma week, which is tomorrow, on Hodgkin's lymphoma, which is also the progress and understanding and treatment. Don't forget to save the spot today. Next slide would be, we would also like to thank our sponsors, Beijing, for their support in making these events possible. And then please remind you that we are here to help. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll-free. Please note that a short survey will be sent to all participants after this presentation, so please do take the time to respond. It really does help us with future events. Thank you, everybody, for being here. Thank you, Abi, for being here and for giving us all of the wonderful information that you did, and we hope to see you all tomorrow.
Thank you so much.